We should probably get started, just so that we can end on time. I'm Joan Ash, and I'm taking Bill Hirsch's place today because he's out of state. We have a very special presentation on a Monday, which is very unusual, but it's a good way to start the week. We have Jay Himmelstein, who is here from Massachusetts, and Rus Hargrave here from Oregon, talking about technology policy in motion. Now, Dr. Himmelstein is a professor of family medicine and community health and many other things, as you can see on here. He holds a number of exalted roles. And when I checked on the website this morning, I saw you had 2 master's degrees.
Yes.
One in public health and one in physiology from the Harvard School of Public Health. And Rus may be known to some of you because he is here in Oregon. He is the technology advisor and senior
advisor of everything.
Again, I checked on the website, and there were many titles there. So I know that they're extremely qualified to talk to us about health insurance exchange. I keep wanting to say health information exchange. And I wondered about the acronyms. You know, we say HIE, and I thought, there's another HIE. It's HIX. That's how they differentiate it. So I learned something this morning when I was checking things out. And I'll turn this over now to Jay, who's going to start.
Yeah. Well, thank you.
And
I think
this is for you.
Is this mic live? Okay, good. Well, it's very nice to be here, and actually, it's always helpful to me to know who I'm speaking to. I was talking with Joan beforehand, and I understand you're mostly. How many are you all students? No. Okay. So we have some faculty as well. So in terms of students, what's the backgrounds? Are we clinicians? If you're a clinician, raise your hand. Researchers? Okay. Engineers? Other lawyers? Uh-oh. Okay. So usually, got to watch my lawyer jokes. Okay. Good. Well, anyhow, so I am a faculty member at the University of Massachusetts Medical School, and I've got this very interesting. I was very involved. I've known Bill for many years, and I got involved in health information technology about 10 years ago when Governor Romney was planning his first run for president, and he said, you know, he thought he was going to be running against Jeb Bush, and Jeb Bush had a state HIT plan, and so he turned to us at the university to write a state HIT plan so he could, you know, say he was doing something. This is at the same time he was working on health reform. Anyhow, so we got involved in HIT at that point at the university and started. The question that the governor was asking is, well, where should we make investments? Is it appropriate for the government to make an investment? And we found that the most appropriate place for the government to make an investment was for the Medicaid program. And we did a series of projects funded by AHRQ looking about what the role of the Medicaid program could be, should be in electronic medical records and HIE. You know, that, as many of you who've studied the HITECH Act, you know, part of what got written into the HITECH Act was specific incentives recognizing the value of the Medicaid program and the importance of Medicaid providers to be incentivized to participate as well. Subsequent to that, I got asked by the new governor when the ACA passed to see if the university could help Massachusetts upgrade its systems to build the information technology for healthcare reform. And that's what Rus and I are going to be talking about a fair amount today. You know, I understand from Joan that you really have not had that much exposure necessarily to HIX, you know, the other exchange. And, you know, what we'd like to do is give you an update about the overall concept, the role of health insurance exchanges, talk about the information technology and the data that's related to building those things, and use specific examples from the two of the leading states, Oregon and Massachusetts, about what we're doing and how we're thinking about this, and then end by coming back and saying, well, what does this mean for you as informaticians of the future? You know, how should informatics get involved, be thinking about what you're doing in terms of health reform? Does that sound like a good agenda? So basically, you know, health insurance exchanges, HIX, are the key central component of how health reform, how the ACA is being implemented. There, you know, and I'll talk about the coverage expansions and the expectations and cost containment. But HIXs have a significant responsibility with the private and the public insurance market. And one of the most significant things is they are going to become the primary means for determining eligibility for Medicaid, as well as the subsidies that will become available through the ACA. And although there are significant differences between the ACA, we now are comfortably calling Obamacare, and the Massachusetts reforms, Romneycare, which he did never own totally. But there's significant, there are some major differences. And I'm going to quickly sort of go through some of what we did in Massachusetts in 2006, talk about how things are different, and then talk about under Romneycare, and then talk about the IT infrastructure. So Chapter 58, 2006, was the so-called Massachusetts Health Reforms, otherwise known affectionately as Romneycare. It was fun. You see that Romney did, in fact, sign the bill, and that Senator Kennedy's smiling in the background. I used to work on the senator's staff, and he said after this, he says, if you see Romney and I smiling while he's signing a bill, one of us hasn't read it. And that's one of my favorite quotes from the senator. But anyhow, the basic content of the Massachusetts reform was there was an expansion of Medicaid. There was a subsidized insurance coverage for low-income adults that allowed them to buy commercial insurance. And this is the part that Romney really fought for. And there was a number of insurance market reforms. And the idea was there was shared responsibility. This is why Romney was so excited about it. This wasn't just a government expansion of Medicaid programs. Everybody had to pay, employers, individuals, and government. And he was very, very strong, as you all know, on the individual mandate and making sure, because that's what you needed to make this work if you're going to keep the private insurers in business. And as part of that, we set up something called the Massachusetts Commonwealth Connector Authority, otherwise known as the Connector or the Massachusetts Exchange. And what this did is, it's an independent state agency. It had two things. People have probably heard. How many people have heard about the Connector and heard about the basic concept of an exchange? I mean, people know about the basic idea of an exchange. It's like an online marketplace. It's Amazon or Travelocity for health insurance. And that is part of it. What the Connector also had is some legislative, had regulatory authority about this determining what makes a health program affordable. And it also had a lot of authority about how to structure that market. And they made decisions that, first of all, the law required that there be the subsidized program called Commonwealth Care. And that's most similar, as you'll see later, to the advanced tax credits part of the ACA, part of Obamacare. And Commonwealth Choice, which is more the Expedia marketplace, where we basically structured insurance plans and made it easier for consumers to make decisions. So the current Health Connector web portal offers a user-friendly shopping experience, and if you haven't been there, you can log on. And I've taken a lot of my friends and family through this, and it works pretty well. It's sort of state-of-the-art 2007 website, in that you can enter, depending by who you are. There's a portal, and if you're an individual or family, it asks you a couple simple questions to get you started on the search. You put in your family size, and then it does a very quick back-end calculation about, in our case, 300% of poverty in Massachusetts under the reforms. And if you say that your income is more than 300% of poverty, then it collects a little bit more information about where you live, whether you're looking for yourself or your family, and then it allows you to search among these plans, which we made gold, silver, and bronze for the ACA. For Obamacare, they've added a platinum level, but basically plans that are grouped by similarities in their actuarial value, and also similarities, therefore, in terms of what's covered in each of those plans. And then once you make a selection, you get to see the plans, and you have the plans presented in a somewhat standardized fashion. And this was really something up to then. You could go to a Blue Cross Blue Shield website or an Aetna website, but you could not see plans on the same shelf that were compared in standardized ways. And then you can see within the bronze plans in this case, there's multiple plans there's multiple plans available that vary by their deductibles, by out-of-pocket expenses, how generic drugs are handled and things like this. And then, like other shopping sites common around that time, you could select different plans and compare them, draw them out. Of course, all Massachusetts plans are above average, because NCQA sort of likes us there. But so the quality ratings weren't that helpful. But you can learn a little bit more about what's in the packages, and then you can go on and detail, get more details. And you'll see even in this bronze standardized plan, that one of the plans has a premium of only $240 a month, and another plan has a premium of $380 a month. And not surprisingly, people tend, when they're presented this way, to go to lower cost plans. This is one of the ideas of how you save money. And they're very, very standardized in terms of what the benefits are. So this is actually pretty comparable. The trick is, for most people, it seems that most people make their decisions now on how much it costs, what's the monthly premium, which is not necessarily the lowest cost. And that's a conversation we might get into. And is whether there are doctors in the plan. So we also have a doctor finder to make sure that the plan that you're signing up for. So this is the connector currently. Now, that was for the unsubsidized Expedia experience. First of all, any questions about that? You know, that's sort of the standardized marketplace approach. Yes?
You've got two plans with the same benefits, but I'd assume a different panel.
Yes.
And the costs differ by a factor of 2.
Yes. Factor of, whatever the math is there. Yeah.
Well, it's actually not that. It's like 230 to 380.
Yeah, right. That's right. That's right. Very similar. So interesting, isn't that? So now you would not have known that because you couldn't have shopped that any other way. And we found that it has made a big difference, and it has affected the plans. So plans submit there's a whole process that the connector goes through of saying, here's the standardized benefits we're looking at, all the plans put in, and then they say, oh my God, we're way out, and you see them changing prices if they want to build their panels. Yes? Go ahead.
So what reaction did you get from Blue Cross Blue Shield in Massachusetts when this came out?
What's that?
What was the reaction from Blue Cross Blue Shield in Massachusetts, the 380 plan?
Well, the thing is, some questions whether they wanted to, that this may have been strategic on their part, that they really didn't want to get in this business, that this wasn't. Now, it's going to change with the ACA, because Blue Cross Blue Shield is already, like many Blue Cross Blue Shields, a fairly dominant plan in the state. And they were a little uncertain about who was going to be coming through. They were afraid of being selected against, risk averse, So they actually may have priced their plan purposely high because they weren't trying to grow. And there's a whole conversation about that has implications nationally as well. Okay. So now what happens if, let's say that the family goes a little different way, and this is to show how the current subsidized plans work. So if you needed insurance, let's get started. You start now, you put in your family size of 4, and in this case, you say, no, my income is not above $69,000, which is 300% of poverty for family of 4 in Massachusetts at the time the screenshot was taken. What happens then? Well, then you're sent to a page which really tells you basically, go find out about this, go to an enrollment worker, and you're referred to a paper process, which would be the more traditional Medicaid eligibility process. Have anybody here worked or familiar with Medicaid? Is Medicaid a core subject here? Okay, so if you're not familiar with Medicaid, it's a great program in terms of very broad benefits. It's very good here in Oregon, but the process of eligibility is very complicated. There's a lot of categorical eligibility. You could have 2 families who have the same income, and one has a disabled child, and they get Medicaid, and this family doesn't. You could have one that if someone's pregnant, they get it, but they, since they're off pregnancy, they don't get it. So it's very, very complicated, and often discontinuous. People get enrolled and disenrolled a lot. So, and there's this paper process, and one of the major actually, I'll come back to that point. So this is one of the limitations of the Massachusetts reforms. In this case, you would go to the paper process, and it might be found, well, if you were between 150% and 300% of poverty, and you didn't have any other Medicaid qualified conditions, you'd be eligible for this subsidized program called Commonwealth Care. If you were below 133 and you were, you might get into the Medicaid program. But it certainly wasn't an instantaneous determination. Nevertheless, Massachusetts, as most people know, was very successful in what they intended to do, which was to get close to universal coverage. There were over 400,000 people who didn't have insurance before or do have insurance. 98% of folks in Massachusetts have insurance. There is, one of the things that drove this and made it successful was the individual mandate, because people, if you don't have insurance and you don't have a 1099 HC, 1099 health care that you put in with your taxes each year, then you're going to be dinged on your insurance, and you have to pay additional taxes. And in Massachusetts, it's pegged at about half the cost of what the lowest cost plan available to you would be. So most people make the deduction, well, gee, if we're going to spend $1,500 to get nothing, why not just spend $3,000 and get myself a inexpensive health insurance plan? Public support has stayed strong. We didn't fall off the cliff. Most employers actually think it worked well. It's been a very well received thing. We're not any more socialistic than we were before this. We were Massachusetts. We're like the west coast of Oregon. So now the cost of health care and the annual rate of increase in health care spending remains a challenge. And you may have seen in Kaiser today they just announced the new health care cost containment commission in Massachusetts. It was never designed, similar to Obamacare, to really have very strong cost containment. The idea was to expand coverage. So that was Massachusetts, 2006 reforms. Now, very similar, signing ceremony. Senator Kennedy wasn't here for this one. You don't see a lot of bipartisan folks at this one. I don't know if there's a Republican who would allow their picture to be taken on this day. But it was with a lot of fanfare, and the basic structure is the same as Massachusetts. You have a Medicaid expansion, subsidized insurance, implementation of insurance market reforms, and there is this concept of shared responsibility. So very similar in that context. However, there are differences, and I'll talk about some of the similarities. So the Medicaid expansion here goes to 133% of the federal poverty level, and it's anticipated. Am I speaking too quickly? Okay. It's anticipated that about 16 million people will become eligible if states fully implement the expansion as the law is written. Another 8 million people will wind up getting insurance through subsidized purchase, and this is going to be through. And this is the part that's different than Massachusetts. In Massachusetts, we reported at the end of the year we have 200,000 people receiving subsidized care. We gave a bill to the government. They paid us back. It was done under Medicaid waiver. The difference here is a subsidized purchase is going to be through advanced premium tax credits, which functions similar to the earned income tax credit. So that now doing this, it's a basically very core Republican idea that the Heritage Foundation has been pushing since 1990, and they forgot about it after the law got passed. But this is a Republican health plan, a way of allowing poor people, allowing the insurance companies to exist, but allowing people who are less well off to buy insurance with advanceable tax credits. We'll come back to this because this is one of the major complexities of the technology, and it's an interesting opportunity, but there's a lot of challenges, and Russ and I will both talk about that. And then there's with the equivalent of Commonwealth Choice, this Expedia marketplace will allow competitive insurance through an insurance exchange, hopefully that structures the experience so that it's simple for people to make decisions. And there's additional business tax credits to promote businesses to continue to support health insurance. So this whole thing got very distorted during the thing. You have these two twins, Obamacare and Romneycare, and Romney saying your kid is ugly, but it's sort of like they have the same genes, the same core. But because of the nature of making this federal, it does make it more complicated. So kids look similar in many ways. So one of the most interesting, and there's a lot to the technology, and I'm just going to focus on a few things just to bring out enough so we can have the conversation about where informatics fits in this. But what the expectation is for the technology here is that there be a first-class user experience. Instead of having to go into a Medicaid caseworker's office and bring in all your tax returns and your wage slips, that people can actually have the insurance purchase be a little less onerous, and having a single streamlined eligibility form. So it doesn't matter. So if you're applying for any kind of government support, have it single, not just for health insurance, interestingly enough, but actually making this, and Russ will talk about this, potentially an entry for all health and human services and modernizing that whole system. And really, one of the most critical differences, and I think one of the most challenging things, is the exchanges are required to determine eligibility for and coordinate enrollment for Medicaid. This is a very, very big change. So you have these organizations which don't yet exist in most states. It's just Massachusetts that has an existing exchange. All of a sudden, taking over responsibility for eligibility and enrollment for this long-standing, very large, very complicated program. And this is where a lot of states are stumbling right now. And I'll just make one more general point, because my son is a computer scientist, and when he heard that I was the PI on a $45 million grant to build a website, which is what it was originally reported as, he said, "Well, gee, Dad, could you just give me a case of Diet Dr. Pepper and $5,000, get my friends together, we'll have a hackathon and build this thing over the weekend." And I said, "That's kind of good," but then I sent in this slide to show just one component of it. So of what's involved in the technology. I think the stack on what I guess is on your left shows things that are happening in the state. The stack in the middle is something that doesn't yet exist, which the federal government is currently building, called a data services hub. And the stack on the right is the different federal databases that have to be involved. So when someone comes in to shop at the exchange, and we'll look over on your, before they even shop, there's all these things have to be recorded in terms of what is considered to be a qualified health plan. You can't offer, because of the insurance market reforms, you have to offer a qualified health plan, which offer the essential health benefits that are mandated by the law and tailored to each individual state. So you have to have benefit plan data loaded in advance. Then someone comes in the shop. The first thing that has to happen, you have to validate who they are. So there'll be a Social Security validation request and response that'll go to the Federal Data Services Hub, go to SSA for a response. And these are happening simultaneously. The law as written will require certification of citizenship. You can't shop on the exchange if you're not a citizen. So that involves Homeland Security. Their databases are pretty open, of course, right? And citizenship verification for SSA. Then there's a whole income verification process that has to happen, where people self-attest their data, their income, but a lot of people don't know what their. I mean, how many people here know what their modified adjusted gross income was for last year? It's not obvious. Actually, there isn't a particular space that says what's your family modified adjusted gross income, because modified by what? So there's a system that's being built where it'll tie up into, I think it's 16 different IRS databases to give a response. Well, yes, this person, Joan Ash, Dr. Ash, you are, your modified adjusted gross income is X, and therefore you are eligible for going shopping. Probably you can just go shop. But some of your students may be told, well, you may be eligible for an advanced premium tax credit. And in that case, you also have to verify whether you currently have insurance. And then there's this whole thing of calculating your advanced premium tax rate based off of your modified adjusted gross income. You get a response back, and then we can go shopping. Okay, so it's a little more complicated than you can do in a hackathon in a weekend, and very dependent on these other systems being built and having service level agreements that can give you the information quick enough so you don't time out on people. So now we can start shopping. So you can see it's a little more complicated than Connector 1.0. And then people presented the data in a way that says, so getting back to the first slide I just showed you in the connector, instead of a health plan costing you, what was that? The cheapest one was $240. You might be eligible for a tax credit of, I'll just make up the number, $40 a month. So that for you might only be $200 a month. And likewise, Blue Cross Blue Shield would, instead of being $380, would be $340. So it makes plans cheaper, but doesn't make up for the differences in their things. So you wouldn't get paid more. You wouldn't get more tax credit for choosing a higher plan. Okay. So anyhow, I won't kill you with this, but one of the challenges that Russ will probably be talking about, in order to do this, the states will also have to be hitting on other data sources within the state, often which are legacy systems, which aren't really that set up necessarily to give very quick responses, on wage data, employment data, family data, So in order to make this system work, states need to create or have access to a web portal. Seems fairly straightforward, but the secure interfaces with the Federal Data Services Hub, state data sources, and health plan carriers. And they need to make major upgrades to their Medicaid systems to be able to send and receive eligibility information from the state HIX to the Federal Data Services Hub. So before I'm going to transition to politics for a second here, but any questions about the general idea of what the new exchanges are required to do technology-wise? Are everybody with me still? Right pace? Okay. And actually, Rus collaborated with us, but I have some, we recently did, there's 4 states that were given money to, get a jump start on the technology. Oregon and Massachusetts, New York, and Maryland are all working on this. And the handout that I've brought you is a paper we did for the National Academy of Social Insurance, which talks about what some of the early lessons of those states who've been trying to build this. And there's also there's a health affairs blog about it as well that you might find interesting. Okay, so we had an election last week. Who won in Oregon? I think Obama won in Oregon, right? So there was a lot of, as you know, a lot of politics. I don't think, do they carry Fox News out here? In the Eastern Mountains, but you wouldn't have known it from Fox News. I mean, the Obama was. I'm forced to watch it when I'm working out at the gym, because it's on 3 of the 6 channels, unfortunately. And you'd think that Massachusetts had fallen off the cliff, and Obama was a Nazi socialist, and if we did this, life on Earth would end and stuff like that. But turns out, and the complications of all the politics of first with the individual mandate, mishigash, and the election, a lot of states have slowed their development, assuming the law was going to go away, hoping that Obama wouldn't be reelected or something like that. And also, it has slowed, because of the politics of it, some of the work, and it distracted the work on the federal. So you're going to see a lot now happening to really accelerate implementation, because some of ACA, Obamacare, has already been implemented. The children's being able to stay in their family plan, and probably some the high risk insurance plan. You may know people who have been affected by this already. But the major changes happen in 2014 when the health insurance exchanges go live and when the Medicaid expansion, is fully implemented. So they've got to really accelerate their work on ACA regulations and implementation. And they've got their own big challenge to build. They've got to build this federal data services hub, which is fairly complex, has never been done before. The IRS is really not that familiar with having other people sort of querying their data, and there's all kinds of special rules that we're learning about in terms of security for that kind of data. And also, I'll talk a little bit about this. There is this thing called the federally facilitated exchange, which was intended as really as a threat. Because we want to make sure as a threat. For those states that couldn't get it together, there might be a few states that were laggard states or didn't have the technology support. But you wanted to make sure that people in those states would be able to get access to the benefits of the ACA. So there's this in the law. There's this possibility for federal facilitated exchange. But what's happened because of all the delays from mostly the red state, Republican-led states, there may be quite a few states that are going to have to be on this federal exchange, and that's quite a complicated build for the feds to do. So those are some things that they have to worry about. On the state side, and we'll talk next about that, I apologize. The states now are really going into full gear, and we'll both talk about that. But the readiness and willingness to do the implementation really varies tremendously. And one of the biggest challenges, because it has one of the longest timelines, is building the technology to support this. There's also a lot of other things we're not going to talk about much today, about the policies that have to be made, the decision about how active a purchaser of the exchange is going to be, how generous you're going to be with your Medicaid expansions, that you have new flexibility. There's a lot of other things. But the technology build takes a fair amount of time, especially connecting to these old legacy systems and creating new interfaces to systems that don't yet exist. So the post-election landscape. This is the this is the election night map. Florida, I guess, eventually came around to be a blue state. But you'll see this was as of election night. The stars are the states that have put in their so-called blueprint and are planning to have their exchanges up and running by January 14th. And you'll see there's about 12 states here. There's been a couple more that have come on in the last week. Secretary Sebelius on Friday extended the deadline for another couple weeks for states to declare. But probably there won't be many more than 15 states that are going to be ready in January 2014 to implement the exchange. So there's a whole other conversation about what happens to the rest of the states. But what the feds have come up with is a transition plan. So on the left side of your screen, you have states like Oregon and Massachusetts will be a state-based exchange, and they'll basically do all the things I talked about with Connector 1.0 plus some additional things, and they'll be operating their own state exchange, which includes they'll have control of their Medicaid program, they'll have control of their insurance market. On the other extreme, we have the 25 to 30, Republican governors who really are still dragging their feet, and who are probably going to have to default to the federal exchange. And that's going to be a very interesting conversation over the next couple of months, and we'll see if that changes. In the middle, you have a bunch of states that really, weren't the early innovators. They would like to do their own state-based exchange. Some of the red states would like to do the exchange because they don't like the idea of the federal government running these things for them. And the feds are offering them a state partnership where initially the technology and other support may come from the feds with a plan for them to transition in 2015 or 2016 for their own exchange. So it's been a long and winding journey. Congress, a lot of folks, Congress is going to stop it. The state courts will stop it. The Supreme Court will stop it. President Romney will stop it. And here we go. The answer is stop it and decide. So now we're really at a decision point for the country and for a lot of those governments. I'm sorry, question? Oh.
Thank you. On your previous slide, you talked about states may determine Medicaid and CHIP eligibility. That's a pretty big thing to do, to interface. How's that going to work?
In which one? In which column we're looking at?
Looking at the bottom of second and third columns.
Yeah, right.
So this means that they have to set up a database of who's eligible, or how does that?
Yeah, well, that's a whole other conversation, and maybe let's come back to that at the end. But yeah, I mean, that's the thing. It's not nothing. Say, okay, we'll do this. What the feds are saying is, we'll help you determine the federal eligibility. We'll make these interfaces to the federal hub. We'll give you the information about the modified adjusted gross income, and then we'll refer people who we think are eligible for your Medicaid program. And then states can focus on. I mean, one way of thinking about it, this might allow those states who can't do the whole thing just to focus on getting their Medicaid program up to snuff. The encouraging thing is, I said there's only 12 or 13 states that are going full bore to do like Oregon and Massachusetts, rebuilding in a single system their exchange and their what we call integrated eligibility system for Medicaid. Over 40 states have applied for it and have gotten money from the feds to upgrade their Medicaid eligibility systems. So that's going to happen. I want to get one other question here.
The slide, maybe more correctly, should say they may continue to run. States do this today. All states do.
Right. So one other question here.
Yeah, so for those states that have declared we're not doing it, is there anything different, when are they the federally facilitated?
They'll be on the federally facilitated exchange.
What's the impact to their citizens of that?
It's going to be really, it could be very messy. It could be very messy. I mean, as Russ pointed out, they already run their Medicaid programs. The Supreme Court, complicated things. Justice Roberts did a very interesting thing in parsing the baby, and it's a fairly technical thing that a lot of people don't understand. He did validate the individual, mandate, which was the core of what the Supreme Court was about. But they did allow states, and I think a lot of the Republican states may be in this, not to expand all the way to 133%. So you could have a situation where people are eligible for tax credits if they're above 133%, but if they're below 133%, the state has, and in between, and that could be really vary from state to state. They may be sort of lost, So instead of 16 million people becoming eligible for Medicaid, it may be 10 or 12, depending on how states choose to do that. They've sweetened the pie to encourage states to do this, but some states still are just, operating on the principle of no. So I think what I might do, because I want to make sure Russ has enough time to talk, I'm just going to really quickly go, there's a conversation in the white paper here about the potential for reusability, things that we're doing in Oregon and Massachusetts, which might be helpful to accelerate the development in other states. I don't think I'll talk about that. I'll just do a very quick sense of what this means in Massachusetts and hand it over to Russ. So what we're doing in the areas in blue here are the new technologies that we're building on top of the legacy systems that are on the right. Okay. So legacy systems, you don't need the details, but the MMIS, the Medicaid Management Information System, is the system that typically does Medicaid enrollments and manages claims payments. So we're not replacing that right away. We're connecting to legacy systems. And the things in blue are things that we're building which we think have the potential to be reused by other states, either in part by the architectural design and the documentation, or depending if they've got compatible platforms, compatible software, compatible legacy systems, potentially could be hosted across several states. So the things in blue represent those things. And I'll just draw out a couple things. All these systems are going to need to have very interesting master data management systems where you can identify someone who's coming in. You'll have to know what we found out about their income and their preferences. We'll have to know what plan they're enrolled in. And one of the things to be thinking about, and we'll have to have some unique identifiers. How does that potentially relate to some of the things you're wondering about in informatics? How can that information be connected with other things that you're thinking about? And the idea being that some of these core things, that we've developed, the portal and the rules engines and the data management systems, could be eventually made available to other states in what we call a Tier 2 sharing example, or in theory, and I say this in theory because it gets very complex in the details, you could have a multi-tenant hosted solution where what we build in Massachusetts, if we find a state that really likes what we did, wants to basically use that, leverage the interfaces we've built, we could have a mirror of that made and have another state operate within the same cloud. They would still have to manage their own Medicaid, in this particular example, manage their own Medicaid and CHIP programs and tie in with their own legacy systems. So that may be a way of accelerating things. So I think what I want to do is I want to hand it over to Russ to talk about more, because he's a technology guy. I'm just a simple country doctor. So can talk a little bit what
from Boston,
what they're doing in Oregon, and then we can open it back to discussion. Thank you.
Thank you, Jay. I do not have as many degrees as Jay, and I cannot speak as quickly. I don't know if that's necessarily correlated. I wanted to know before I started, how many people are actually from Oregon? I mean, how many people live here now or have lived? Some, but it's a minority. Okay, so the first thing I want to emphasize is with that technology slide that Jay had with all of the lines showing how complicated it is so much more complicated than that. I was biting my tongue all the way through, not to jump up and down and say, hey, before you even authenticate anyone onto the system, and we saw that little arrow going up to the Social Security number, how do I know you're you? Right? And, today, if you're doing this commercial, if you're going to go on to Amazon, the way they know you're you is that you got those 3 digits on the back of your credit card number. That's all they care about. It's a valid use of the credit card. That's to them knowing that you're you. If you're a human service or a medical service or organization like Medicaid today, the way we know you're you is you come down to the office, we look at you pull your wallet out, look at your driver's license, a few other things. That's how we know you're you. How are we going to know you're you here? Going up to the Social Security number and saying, well, yeah, the one he entered matches the name he entered, that's not enough. So it's way, way more complicated. So Oregon started on this journey very early. We were one of the early innovator states, so-called, because a number of grants were given away before the establishment grants came online in order to get some states out in front so that they could demonstrate and perhaps develop artifacts that could be reused. And it's an important part of Oregon's responsibility to promote reuse. And I've been doing that as much as I can. I wanted to say that we started right at the end of 2010, so we got started on this very early. We were able to leverage some procurements we already had in the pipe. And so at this point in time, I'm showing you screenshots that probably few states can show you other than Massachusetts. This is the actual Oregon connector, which is largely built, although not completely built. And one of the things that really isn't done at this point is one of the hardest pieces of heavy lifting, the integration, all of that, all those other systems that need to be included, particularly the integration back to legacy. So that is one of the major challenges still facing us. But we do have all of those compare, plan, and search and so forth screens similar to what Jay was showing you, but they're 2012, not 2006. So what is Oregon? If for the purpose of health insurance exchange, it's a middle-sized state in terms of population. Today, most people, as in every other state, get their health insurance from their employer. There's another 250,000 that get their own individual health insurance. There's a little over 500,000 on Medicaid and Medicare. And then there's a little over 500,000 that are uninsured. So, and that's really similar to the rest of the nation. So that's the breakdown of the population today. And we're a little simpler than most states in terms of the number of carriers. There's over 90% of this population is served by only 7 carriers, which is really good from our point of view in running the health insurance exchange project. We only need to get, lately it's been around 12, 13 carriers in the room to have a meeting with everyone, to be able to talk, actual face-to-face personal conversations with CIOs from each of these carriers. That's a luxury that states with a couple hundred carriers that are eligible for medical coverage in their state, they can't do that. And the carrier integration is one of the biggest challenges. It's not the biggest, but it's one of the big challenges. So if you look at the health insurance exchange, as Jay explained, comprising both qualified health plans from private carriers and public offerings that are based in Medicaid, how much do we expect to enroll through that exchange, and where are they going to come from? So we expect that the Medicaid expansion will bring on at least another 225,000 people. This is a highly guarded number at the agency I work at, so I wanted to show more aggressive projections, but this is the projection that we're comfortable with. And we expect more than that to come in and select qualified health plans through the health insurance exchange. And so this is the combined enrollment that'll happen by 2015 through the health insurance exchange in Oregon, according to our projections. And we expect that these people are going to come from 25% from the current individual market, 40% from current small group, and 22% from uninsured. So it'll drain that uninsured pool somewhat. I wanted to talk a little bit about the structure. This might not seem like an informatics problem, but when you graduate and go to actually implement these things, it's actually not so hard to get the bits in the computer to line up as it is to get the people and the different entities they represent to line up. And so Oregon is similar to other states in that there's 4 major players in the states. The health insurance exchange itself will be run by a public corporation that's been established by our legislature and has been convened. It has its own board that doesn't report directly to the agency or to the governor. It's a public corporation, similar to PERS, if you're familiar with the Oregon retirement system. We have 2 major state, geez, that wasn't even a joke, or maybe it was. I didn't want to touch that one. 2 major agencies involved here. The Oregon Health Authority, obviously, which is the agency that sets Medicaid policy, and it's the agency that wrote the Early Innovator Grant and kicked off the health insurance exchange work here in the state, and the Department of Human Services, because for lots of Medicaid, it will still be done in field offices. It does, if you're developmentally disabled, for example, still require a personal face-to-face contact. So some Medicaid will not be able to only have the online experience all the way through to enrollment. So it also involves the Department of Human Services, and there's also the Oregon Insurance Division. So you've got to get all of those people moving the same way, thinking the same way, and then there's also the legislature and also the feds. Fortunately, in Oregon, we have a great partnership, and our championing of health insurance exchange goes way back before the ACA. In 2007, the Oregon legislature asked what was at that time the Department of Human Services to prepare a health insurance exchange plan. So that's way back at the end of 2007. So our strategy, as I mentioned, we got an early start because we were able to leverage an existing procurement that the Department of Human Services was doing, and it wasn't even aimed primarily at Medicaid. It was aimed at all the other human services as well as Medicaid, SNAP, TANF, all the employment-related stuff and so forth that the state agency does. So fortunately, their strategy was to use a commercial off-the-shelf product. And because that product was off-the-shelf, it was robust, what normally happens in states is we build custom solutions. Or we bring in a custom solution that another state built, and that's called a transfer solution. If you build a custom solution yourself, and if you get the requirements right and execute correctly, you can wind up with a nice solution, but it's not likely to be reusable in another area. It was built customized just for that one area that you targeted. Even more limiting if you brought in a transfer solution, because that was customized for some other state, which hopefully is similar. Because we bought an off-the-shelf product, it was actually pretty easy to extend it from the human services that were targeting the procurement we were able to piggyback on that and move it over to be efficacious for health insurance exchange too. And so we felt that the products were ripe enough that you didn't need a commercial solution, that the advantage of having a whole company invested in evolving that solution were really significant compared with having to evolve it with what the best we could do with state employees. And this is one of the most serious challenges that a state faces with any of these solutions. If you build it yourself, you'll get the money to do that once. You won't get the money or the resources to keep it up, and so the stuff comes very out of date. So that was why we went in this particular direction. Now our vision is to not only use it for health insurance exchange. I want to try and introduce a different idea of reuse here. See, the idea we had around reuse wasn't so much carving off the health insurance exchange piece, just the medical piece, and then trying to share that across states. That's certainly a valid reuse model. Instead, we wanted to implement this technology and then reuse it across both agencies, reuse it across all of these different health and human services that the state has to determine eligibility for, to manage enrollment in, and to be able to use analytics across all of that data because they are so similar. It's the same family that's on SNAP, that's on Medicaid, as an example, and so forth. So our vision of reuse was to implement it across the scope of both of these agencies, but there will be different experiences. So if you go in through the health insurance exchange portal, it'll be like what I showed you in the beginning. Not only will it be all about medical and only medical, but it'll be a shopping experience. And the people involved in that experience are very concerned that it doesn't look like a government offering. You know, that's not the population they're targeting, and a lot of the population they're targeting doesn't want it to feel like a government thing. They want it to feel more like Amazon. And so you'll see that type of user experience here. If you go in over here, the Department of Human Services that is operating this portal is much more concerned with determining all of the benefits you might be eligible for than they are about just getting you medical. And so they're unabashedly going to talk to you about all these government benefits that you might be eligible for. And so the experiences will be different. The neat thing is, it's all one system. We went out and purchased an integrated stack from Oracle. And so regardless of which door you go through, as eligibility is being determined, and medical eligibility, as an example, will be determined through either of these doors. it goes back to the same rules engine, Oracle Policy Automation. It creates a case which has the same client master. So we know who you are. We can bring in the data that you've already entered last year, yesterday, or someone else in your family entered. So it's one brain in that the logic is common and the data are common. Jay?
So Russ, is there a, I don't know if it's just to hit this thing, I guess. Is there any connection? I don't know how Oregon's Health Information Exchange is set up, but is there any connection between Health Information Exchange and this, and where are there similar kind of client identifiers?
Perfect segue to the next slide. Was there another question? Because I'm going to take that as an opportunity to segue. Yes?
I was just reiterate that question in that what's your protocols for patient identification or client identification?
Okay. So, both questions are really around data, around information, right? So let's start to talk about it. So today, it's huge. I just did this last night, so I'm just becoming acquainted with it myself. These are some of the system areas. I mean, we actually have probably 400 systems that comprise this scope. So I'm really simplifying it. These are not actual systems, but they're areas that systems operate in. And where there are multiple systems today for intake and eligibility, I've tried to show that as a fractured line. So the blue ones are new ones that we're building, don't exist yet. The brown are ones that are already in. So we do medical intake and eligibility in a number of disparate systems. We do human service intake and eligibility in different disparate siloed systems. We have implemented to get back to your question, our health information exchange just this summer. And that is rather rudimentary health information exchange, but it does include a provider master. And of course, it includes the exchange of health information, but it's NHIN direct, if you know what that is. So it's really a lot like secure email. It's not a lookup, a record locator type system at all. In fact, there's no storage of health data in this system. The only data that are stored is the provider master, the directory. And so on. I think the point I wanted to make with this slide, and looking at the time, unless there's a specific question, is how it will change. So each one of those buckets, those areas, even within that area, like I showed eligibility and I had those fractured lines, you can't get a view of a client across the ERDC, TANF, SNAP, and medical. Those are 4 different system areas. You can't easily see across those areas. You can't get a 360-degree view of a client, partly because the case and eligibility information are in disparate systems, but also because we don't have the master data management. The client master itself isn't able to come up with a unique instance of a person. That problem will be solved over time, a number of phased implementations. And by the way, when the health insurance exchange goes live, that's the door on the left in the house I showed you earlier, this one. This will also go live either at the same time or before. It's currently scheduled to go live before. So very aggressive compared with what other states are doing. Most states are racing as fast as they can, as Jay explained, just to hit the date and get this thing in. We're actually started at the same time with both of these. So we've doubled the race because this is implementing not only medical, but in the initial release, it will also do SNAP. And this is currently scheduled to go live a little bit earlier. Over time, though, over the next, let's say, 5 years, we will build out these client portals, all medical, all the qualified health plan. For medical, it's only eligibility. The enrollment and the payment, that's what your MMIS system does. Not sure if we're moving that onto this platform. But all of these other areas across all the human services, including medical, will all be aggregated into one system, one database, with one client master. And that's great, because now we will be able to get much more out of our analytics. we still have some disparate systems. There's, of course, the all-payer, all-claim system is different. It has different data. There's a whole number of public health systems that will probably remain different for a number of reasons I could go into if you're interested. And it's not clear that we get to one provider master either.
So, is that clear? I think that one of the things, I think we'll come back to this in the discussion. But I want to just sort of close with a couple thoughts and then a couple questions. So what Russ has started to introduce here is, the feeling is that there's this huge government investment. You all know about ARA and the high tech. Billions of dollars are there. There's already over $1 billion that's been committed to building, did I say $1 billion? Yeah, several billion dollars have been committed to building the health insurance exchange infrastructure. And we didn't talk about it today, but the all-payer claims databases, and I think it's called all-payer, all-claims here in Oregon, is something else that states are making big investments in, because that's essential in order to manage the reinsurance and the risk adjustment systems that all states will have to make these insurance marketplaces work. So these huge investments are being made, and one thing I'd like to, whenever I talk to an academic audience, I like them to be thinking about is, what can we be doing to sort of leverage this data? I know you folks do some really great stuff mining the Epic EMRs and stuff like that, and I imagine some people are thinking about if you really had a true, centralized database or some way of calling out for statewide EHR, so people move out of Kaiser and they're somewhere else, and you don't lose them, and and they go out of the Kaiser system, more complete. Think about the analytic possibilities, informatic possibilities if we leverage all of these investments. I mean, that's something I think that we need leadership from academic leaders like yourselves about what could be done and how people like Russ and I should be thinking about the builds that we're making in these big investments. So I think we have 2 minutes left, so I'll just close. These are some questions we can talk about, but what do you all think about the role of bioinformatics, in HIX and health reform? What are the implications for data, for research, and how do we take advantage of all these investments? So I think I'll end here. And should I take one or two questions, or should I end and then stay around for people afterwards?
Why don't you take a few minutes for
questions? Any questions that people have about this, or thoughts? I'd be more interested in your thoughts. I don't know if I have any answers. So yes, go ahead.
I'll just say that I kept looking at this and thinking about the universal identifier.
Yes.
And it seems like we're creating another system to be disparate from the health information exchange once we try to get to that. And I know that we've kind of talked about this, and this isn't really a question, but it just seems to me, why are we not? And I know that there's government.
Have you all studied that whole thing? I mean, why isn't there? I mean, that must be a constant issue for your EMRs of why aren't there universal identifiers? I mean, I think there was a law once that was passed to create a universal identifier, and it got taken back, right?
And they amended it.
Yeah. It's saying amended it, but you can't do it. Yeah.
I don't know if it's a question, but just a thought on it.
Well, it's a thought. I think what's happening is a lot of very complex workarounds are happening. Russ and I didn't get to it today. It's a whole other conversation. And I'd be interested to hear how he's doing it in Oregon, but in Massachusetts, how we're going to go about client identifiers without having a true universal identifier, and how you validate who they are. And there's a lot of private systems that have been developed to sort of, without actually giving your social security number, figuring out with high likelihood that you are who you say you are, and those kind of things. But unfortunately, it would be a lot, from a technology, from an informatics point of view, wouldn't it be nice to have a universal identifier? I think I'd agree with you on that. So I think, given the time, why don't we stop here? I want to thank you for inviting us, and I'll be more than happy to stay around with Russ for a few more minutes as well. Thank you very much.
Thank you.